Good evening, everyone, and welcome to the August 14th meeting of the Washington Hospital Board of Directors. It's good to see everyone here this evening. If you'd all join me in the Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Dee, if you'd take the roll call, please.
Director Stewart.
Present.
Director Nicholson.
Present.
Director Wallace.
Present.
Director Yee. Present. Director Eben.
Thank you very much, Dee. Tonight, we have an opportunity to honor Nancy Farber, who has recently retired as the CEO of Washington Hospital. She retired after 35 years of service, 25 of which were as the hospital CEO. Those 25 years have seen spectacular progress in all areas of the hospital. You'd notice, first of all, the quilt that's here on the side. This is a quilt that was presented to Nancy by our nurses at a hospital-wide event that celebrated her 35 years as an employee of the hospital and 25 as CEO. Each quilt square represents nurses from nursing units and other clinical programs. It's a beautiful quilt that you can admire here when you get a chance. We're privileged here tonight to have several elected officials with us who have come to present proclamations to Nancy. It's wonderful that our local officials have chosen to come here tonight, take time out of their busy schedules and be here to present items to Nancy. So we'd first like to begin doing that. I'll invite each official up here to the podium, and Nancy will get you to stand up there with them. And we'll first have Richard Valle, who's a member of the Alameda County Board of Supervisors. Richard has been a good friend of the hospital for many years, and it's good to have you here, Richard.
Thank you, Chair Stewart, board members, and distinguished guests. Nancy, when we write these commendations, sometimes they're difficult to write because you don't know too much about the person, so the print is really big. But if you look at this one, the print is really small. And the reason for that is because of the tremendous accomplishments that Nancy has accrued over the years. Beginning with the fact that when I came into this very space many years ago, and I'm not sure if this was the men's department or the women's department of Capwell's. We all remember that. So you transformed this facility into a health facility. In fact, you transformed the entire corridor of Maury into a health net, a safety net for people in our cities. The level of commitment and your accomplishments are beyond this commendation. I want to say that when I've been in a pickle or a jam with my two parents, 95 and 93, a phone call to Nancy always helped me. But when I've been in a pickle with a neighbor, somebody down the street, who was facing a genuine life-threatening crisis, a phone call to Nancy took care of that individual as well. It didn't matter who it was, what their level of income was, what their standing was in the community. She was always there for me, and I will always remember that. There are legends in the Tri-Cities, and I'm not going to name names, but we all know, respectively, in Newark and Fremont and Union City, who those names are. There are very few who reach the level of being a legend in your own lifetime, and you are one of those. So tonight you join a very distinguished and elite group. If your future lifetime has anything to do with the rewards that you've given back to our community, I know that you're going to be well taken care of in that future lifetime. Thank you on behalf of the people of Alameda County, and thank you on behalf of the Board of Supervisors, and congratulations on your retirement.
Thank you very much. Okay, we'll come on the other side.
Thank you very much, Richard. That was very, very kind. We'd now like to invite Lily May, the mayor of Fremont, up here. I must say, I can't remember the last event where we've had all three mayors in one place. This is very, very nice. Thank you.
Well, thank you for this wonderful opportunity. On behalf of myself and the entire City Council of Fremont, we feel so fortunate to have this opportunity to honor Nancy in her retirement and to recognize the wonderful accomplishments. We are a little bit biased, I think, in the sense that Fremont is the home for the healthcare facility at Washington Hospital. And I always tell people that I'm a little biased because my two best products that are made in Fremont are made and products of Washington Hospital. But truly, I feel blessed to have joined the city at the same time that you joined in 1994 in terms of your leadership. But I know that you were also the chief for the strategic planning, which is so critical. And right now, when I look at some of the needs of our city as we're expanding and growing, and the healthcare needs also, we are fortunate and we're very excited that you have led a wonderful effort in building the foundation by which we stand on and to delivering so many of the services, whether it's the critical care, the emergency rooms, the maternity wards, and also just the general services that the hospital and the staff has provided. One of the things that I personally have also seen that I really value with you is that your experiences as a mother, as a community member, really also translate into some of the services that were being offered in that leadership. Something so simple as recognizing, and I mentioned it earlier, that nationwide right now there's a lot of fear or awareness of the opioid crisis, and your conscientiousness in terms of making sure that the staff is trained and then also allowing us as the community members to participate in that allows us as a community to be your partners in delivering the education and the health care that we so need. Thank you for every year with the top hat and the efforts and the thoughtfulness and the focus by which you select your projects and allowing us to participate in that effort. And so I just wanted to say it's been a delight. It's been very humbling for me as a new mayor to have someone as a great leader, as a partnership, and to share your historic knowledge with me. And so I wanted to say on behalf of the entire council, again, congratulations on your retirement, and we look forward to hearing more from you as you relax, and looking forward to also working with Kimberly in the future. Yes, thank you.
Thank you very much. We're gonna, I think they want us there.
Okay.
Here we go. Thank you for what you're doing. I know those are rough times now with the navigation center, but courage. Courage.
Next is fun.
No. Oh, no. Well, we're alphabetical.
Oh, right.
No, I mean, I don't know, it's up to him.
Yes.
I think if they made you alphabetical, you should stick with the plan.
I'm not sure, but it's
Wait. While they're discussing that, we'll invite Carol Dutra-Bonacci up, the mayor of Union City.
Right.
Thank you very much, Dr. Stewart. I thought for sure it was going to be alphabetical, which means F-N-U, but you didn't do that. So Lily was right. She said it was going to be fun, F-U-N. Exactly. Yeah, exactly. But in any case, I am very honored to be here today and wouldn't have missed this for the world because, as most of you know, I was involved for a lot of years with Washington Hospital Foundation. And through that foundation, I was able to get to know Nancy. I looked forward to our quarterly meetings as well as when I was president, the meetings that were more often, because I was just always so impressed with the passion Nancy showed for the hospital and all of the programs. And it wasn't just passion, it was knowledge. And with the healthcare reform, when that was coming in, the worry that was behind it as well, because Nancy always wanted to make sure that everybody got the very best possible. And when those new rules and laws started coming into play, we sat here and listened to her worry and try and figure out how the patients would continue to get the best care that they possibly could. So, and then certainly in the field of mental health, Nancy and I had several conversations about how to try and get the South County, the mental health programs and facilities that they needed here, as opposed to having those people need to be transported somehow up to North County for the services. So because of all of that passion, Nancy, we are all going to miss you. However, with Kimberly coming into your shoes, as they say, she's got some big shoes to fill. But you two have worked together for so many years. I know that it's going to be a seamless handoff. So we look forward to Kimberly, and we also look forward to you being here as often as you can with Calypso. Because as far as I was just so thrilled to say, oh good, she's not leaving, she's coming back with her one of her other passions in life, her dogs, and using your dog to help with patient recovery, because I'm certainly a believer in animals being able to speed up the healing process. So that being said, I did bring along a proclamation. I don't have any fancy wood or glass or anything. I just have my little piece of paper, but it's the words that speak volumes. So this isn't just from me. It's certainly from the entire Union City City Council and residents of Union City for everything you've done over the years to make the lives of the residents of Union City, as well as the entire Washington Township area, much better lives. So here you go.
Thank you very much. Phil and I are loving our new role.
I bet you are, definitely. If they had cats, I'd bring on cats.
There are jokes about herding cats.
Oh, well, then I've got plenty, so you can practice.
And now we'd like to invite Al Nagy up to the stand. Al is the mayor of Newark, and I haven't by any means meant to have you be last, Al, but these
I just thought you
women-
were saving the best for last.
That's right. There we go.
Well, thank you, Chairman Stewart and board members of the Washington Hospital Healthcare District. It's certainly a pleasure to be here this evening to present Nancy with this commendation from the City Council, but also from a grateful citizenry of the citizens of Newark. As I look across that quilt, I see the commitment and dedication of Nancy woven through that quilt, and certainly woven through this hospital for 35 years. And you know, as a mayor, and as a resident and as a user of this facility, it is just so wonderful that we've had the type of leadership that we've had in our communities for these numbers of years. And you know, this area is really a dynamic area. And part of what makes it a dynamic area is that we have a hospital that's dynamic. And that dynamicism is basically comes from the leadership, and Nancy, you've certainly played a large part in that over these many years. And I know I would be remiss if I didn't mention that I did serve on the Washington Hospital Development Corporation for probably a number of years, that maybe even the longest.
Yes,
Okay.
absolutely the longest.
Okay. And you know, one of the joys of that was seeing the growth of this community hospital that serves so many people in our Tri-City areas, and actually throughout Alameda County. So with that, I would like to read just not all of the whereases and what fors, but just one small part of this, because it's a large statement, I think, as to the commitment and the value of the person, Nancy Farber. It says, whereas after 35 years of dedicated service, Nancy D. Farber has retired. Now therefore, I, Alan L. Nagy, Mayor of the City of Newark, on behalf of the Newark City Council, do hereby commend Nancy D. Farber for her untiring work and dedication to the health of our community. As a result of her dedication, vision, and strong leadership, Washington Hospital has earned numerous awards and accolades and has been named one of the top 100 hospitals in the United States by Healthgrades, placing the hospital among the top 2% of U.S. hospitals for clinical excellence. And Nancy, I'd like to present this to you, and thank you again for all of your service, and I want to wish you a great retirement, and stay away from the hospital for a while and really enjoy it. All right.
Thank you so much.
My pleasure.
Right on. Thank you, Al. Al has been a long-time friend of the hospital. We've appreciated all of his service in the hospital. I'd like now to invite Matthew up. Matthew represents Kansan Chu from the California State Assembly.
Hi, I'm Matthew Jorgens from Assemblymember Kansan Chu's office, and I'd like to present this resolution to you. It bears signatures of Assemblymember Bill Quirk, Assemblymember Kansan Chu, and Senator Bob Wykowski, the three representatives of this area in the state legislature. And there's several whereases, but you know, when you work for as long as you did and do as much good work as you do, you get a lot of whereases. So just wanted to thank you for your work on behalf of Bill Quirk, Kansan Chu, and Bob Wykowski.
Thank you. I think he wants the picture. Thank you.
Thank you very much. I'd like to speak a little personally for just a moment. This board of directors has had a very, very long tenure in working with Nancy. Most of us have worked with Nancy for over 16 years. The man sitting next to me here, Mike Wallace, has served on the board of directors since Nancy was first put in as CEO. We won't talk about length of time. We won't talk about age. However, we have had many hours and many days of struggling and talking and learning from Nancy, and also working through programs that have benefited the hospital and benefited, most importantly, the citizens of the district. We as a board would like also tonight to present a commendation for Nancy. We first of all need to take action on that, and so I would ask Jeannie Yee to present that action item.
Mr. President, I move that the Board of Directors for Washington Township Healthcare District commend Nancy Farber for 35 years of service as an employee of Washington Hospital and 25 years of service as the Chief Executive Officer.
Thank you. Second. We have a second. I'd like just a moment, and bear with me as I read that commendation. I think it's important to hear. I think Nancy, as our mayors and representatives have mentioned tonight, Nancy's service has been a service of tremendous value to this entire area. And I would like just to read that commendation before we vote on it. In recognition of dedication and commitment to Washington Hospital healthcare system, The Washington Township Healthcare District recognizes and acknowledges Nancy D. Farber for 35 years as a Washington Hospital Healthcare System employee and 25 years as Chief Executive Officer. Ms. Farber brought the core value of the patient-first ethic to the hospital, which is now ingrained throughout the healthcare system's culture. During her tenure, Ms. Farber led the implementation and expansion of numerous notable services, including the Institute for Joint Restoration and Research, the Taylor McAdam Bell Neuroscience Institute, the Ohlone College Student Healthcare Center, the Washington Outpatient Surgery Center, as well as many other programs for uninsured and underinsured community members. Ms. Farber has been a faithful proponent of an independent and locally owned and operated hospital. I'm sorry, but I need to repeat that. That is so terribly, terribly important. She has been a faithful proponent of an independent and locally owned and operated hospital. She formed the Washington Township Medical Foundation, which currently is home to 90 primary and specialty providers caring for thousands of Tri-City residents to ensure they have access to comprehensive care locally. Ms. Farber created and implemented a long-range facility master plan, which resulted in the successful construction of the Central Utility Plant, the Center for Joint Replacement, and the now renowned Morris Hyman Critical Care Pavilion, which opened in November 2018 on time and on budget. She also oversaw the successful efforts to acquire numerous properties that strengthened the healthcare system's ability to enhance access to outpatient services. To better serve residents, Ms. Farber also established a strategic affiliation with UCSF Health, bringing academic-level medical care and programs to the community. Overall, the healthcare system experienced unprecedented financial success during Ms. Farber's tenure, despite a tumultuous and unpredictable business environment. As a result of Ms. Farber's untiring efforts and strong leadership, Washington Hospital has earned numerous awards and accolades, including magnet status and being named in 2018 as one of the top 100 hospitals in the United States by Health Grades, placing the hospital among the top 2% of United States hospitals for clinical excellence. With highest regards and accolades, we proudly present this certificate of commendation to Nancy Farber. So reads the commendation. Are there any other comments from board members before we take a vote on that commendation?
I would just like to briefly add that I've been fortunate to have worked alongside Nancy for 30 years, going on 30 years, and the 25 years that she has been the CEO, she has managed to spend over $8 billion, which is a lot of money. But what's impressive is that she earned substantially more than that and plowed that back into the services that we provide here at the hospital. And she has been I've learned so much from Nancy, not just her business acumen, but her ability to bring such terrific care to the residents. The high quality of care at Washington Hospital is second to none, and the culture of the hospital is just a wonderful, wonderful thing to behold. And so I am certain that the team that Nancy's built, the culture that she's instilled, will continue to do us wonders in the years ahead. So thank you, Nancy. Thank you so much.
Any other comments from board
Well, I'll
members?
keep it short. I think Richard Valle said it very well. A legend in her own time. That's a remarkable accomplishment. The truth is that this community, the residents, the patients and their family all owe Nancy a deep debt of gratitude for her leadership, which has created this institution as it sits today. Thank you, Nancy, and congratulations.
Any other comments? If so, we'll take a roll call from Dee.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye.
Director Yee.
Aye.
Director Epen.
In that case, I can take the commendation and present it to Nancy. Let's all go over.
It's a lot of money.
At this point, I'd like to take a brief break where we can have a couple of refreshments and each one of us may have a chance to congratulate Nancy. We'll just take a brief break and do that for a few minutes. Thank you. We're going to reconvene now our meeting and again, thank everyone who's participated this evening with the commendation for Nancy and the various proclamations. It's a wonderful thing. Wonderful thing to have done. Thank you, everyone. Our next item on our agenda will be our education presentation. And Kimberly, if you'd like to introduce that for us, I'd appreciate it.
Yes, it is my pleasure this evening to introduce Dr. Jacqueline Chu. She is the medical director of the Washington Prenatal Diagnostic Center. And Dr. Chu is a perinatologist and professor of medicine at UCSF in the Department of Obstetrics, Gynecology, and Reproductive Science. She is board certified in obstetrics and gynecology with a subspecialty in maternal fetal medicine. Dr. Chu earned a Bachelor of Science cum laude in biology from Union College in New York, and then received her medical degree from State University of New York, Syracuse College of Medicine. She completed a residency in obstetrics and gynecology at the Milton Hershey Medical Center at the Pennsylvania State University. She finished her training with fellowships in maternal fetal health at Rush Presbyterian St. Luke's Medical Center in Chicago, and in advanced fetal ultrasound and invasive procedures at University of Colorado School of Medicine in Denver. So I'd like you to thank you, Dr. Chu, for coming here this evening.
Thank you, Kimberly. I greatly appreciate the opportunity to be able to present our recent developments at the Prenatal Diagnostic Center. And I want to extend a thank you also to the members of the board for this invitation. So I want to start by remembering that it's 2 years ago, almost to the day, that I was having the privilege of being here to present to you what at that time was a dream, a vision for a prenatal diagnostic center at Washington Hospital. At that time, our clinic was very much still in its infancy. We hadn't moved into our new space yet. We were still working with per diem sonographers, and we had a ways to go. And a lot has happened since then. I have an amazing team at our prenatal diagnostic center with a lot of achievements to share. I have two dedicated, highly skilled sonographers that perform our ultrasound exams from the beginning to the end. We have a superb genetic counselor who is the access point for our genetic testing, state of the art at UCSF. And she is able to speak with our patients in terms that they can understand for education and making the right decisions for them. We are fortunate to also have 2 staff members, front office, back office, who understand the concerns of the families coming through, who very much, many of them, have a reason for being in a high-risk obstetric unit. And lastly, I have a highly skilled office manager who helps us in every conceivable way in our clinical operations. So let's go on a road trip and a tour. As we enter into our waiting area, we tried to create a serene environment where the women and their families can feel welcome. As you come into the back portion of our office, we pass by the genetic counseling office and come to 2 ultrasound rooms, which are fully equipped, state-of-the-art, and also our procedure rooms for invasive diagnostic procedures, amniocentesis, and chorionic villus sampling. And then in the heart of our clinic is our ultrasound room. And you can see where we try to carry on our theme of serenity and women-centeredness, have space for the families, the women's major support system, and of course our state-of-the-art ultrasound equipment as well. So I would like to take a moment to thank the administration at Washington Hospital and at UCSF for their vision, for their support, for their resource allocation, beginning with the vision, of course, with our dear Nancy Farber, who really helped us set the groundwork and passed the torch on to Kimberly Hartz, who is going to do wonderful things to carry us forward. I particularly appreciate the monthly meetings that we have with open ears so that we can discuss all that is needed, and it's really helped us to become the prenatal diagnostic center that we are today. So the first order of business really on our strategic development plan was, of course, to be able to provide the highest quality of ultrasound. In order to do this, we needed to have sonographers. We were able to hire 2 sonographers, and after a year of daily hands-on sessions and instructions and undergoing quality assurance, we were able to achieve this mission of having the highest quality of ultrasound. And one sonographer recently was able to achieve the highly advanced fetal echocardiography certification from the American Institute of Ultrasound and Medicine. This is a high-level recognition that only about 5%, at the very most, 10% of sonographers are able to achieve. Once we were able to achieve this, then we needed to realize this accomplishment through recognition. So we applied for accreditation by the American Institute of Ultrasound and Medicine. This is a really arduous process, where we need to provide proof of adequate training of staff, comply with all scanning criteria, submit multiple images for review, multiple cases in all categories, as well as abnormal cases. We needed to demonstrate adequacy and timeliness of ultrasound reports, and of course all the compliance issues with safety, infectious disease, et cetera, et cetera. This process took us a little over a year to accomplish, but we got it on our very first try. We were accredited in all categories of ultrasound in obstetrics, and we are now able to use the AIUM logo on every single one of our ultrasound reports. Simultaneously, while working to achieve our high-quality ultrasound, we wanted to implement what's actually an organizational concept, a concept of our one-stop shopping for first trimester prenatal diagnosis. This was originally tested in the Fetal Medicine Foundation in London, and was found to be extremely effective. And it's now instituted widely in many institutions in the country. And the idea here is to allow pregnant women to come in just one prenatal visit to have many of the testing and results in just one day. So this is how it works. Patient comes in the first trimester of her pregnancy, wanting to understand the overall general health and genetics of the pregnancy. So she starts with having an ultrasound where we measure a special area behind the neck called the nuchal translucency. This has a correlation with chromosomal disorders such as Down syndrome. We look at the general overall anatomical structure of the baby and assess the overall health of the pregnancy. We take the data obtained from the ultrasound and place it into the state calculator in order to come up with an instant risk result. And this is from the California Prenatal State Screening Program. Once we have this result, we share it with the patient, and then the patient can undergo genetic counseling in order to go into further detail about these results, as well as to review family history and other components of her medical past that come to bear about risks for the pregnancy. From there, the patient can go on to decide to have further blood testing or even invasive diagnostic procedures, such as chorionic villus sampling, which I'll talk about here in a minute. So, 2 years ago, the next 3 slides are from my talk here 2 years ago, where we had plans. We had really big plans to help with the health of the mother and the fetus. We wanted to provide advanced 2D and 3-dimensional ultrasound in order to assess the health of the pregnancy, identify abnormalities, and we do that. We wanted to be able to provide Doppler flow studies in order to assess the physiologic functioning of the maternal fetal placental unit. We check out the blood supply to the brain, to the placenta, to the uterus, and we do that. We wanted to be able to provide fetal echocardiography, which is a special ultrasound examination in and of itself of the fetal heart, in order to assess both the structure and the function of the heart. And we do that. We wanted to provide genetic carrier screening for over 150 disorders that can affect the babies and result in birth defects, some of which can be detected by sonogram and some of which cannot. And we do that. We also wanted to be able to provide comprehensive genetic counseling, personalized genetic counseling, so that the patient's entire history gets reviewed and her decisions that she wants to make that's right for her family and her future, and we do that. So the next thing on our plan, what we wanted to do, is we wanted to be competitive within the community. We wanted to be unique and stand out for our services that we can provide at the Prenatal Diagnostic Center. So we developed the chorionic villus sampling, and this was developed just a little bit over a year ago. And what this is what's essentially a biopsy of the placenta. It's an invasive procedure that is performed by placing a needle under ultrasound guidance into the pregnancy and into the placenta, taking a little snippet of the placenta and moving on. This procedure is typically performed at large university centers and whatnot. It's performed at UCSF and at Stanford, but only at their main sites, not at their satellites. It's performed at CPMC. and this is to determine the genetic health of the fetus for testing. And we have now been recognized for this program. We're receiving referrals from the East Bay, the South Bay. We're receiving referrals from the Palo Alto Medical Foundation, maternal fetal medicine community as well. And on that same note, what else? We have developed a joint UCSF Washington Hospital Fetal Cardiovascular Center program, which is, we're lucky enough to have a pediatric cardiologist come from UCSF to our center. So we have on-site fetal heart exams. Having a pediatric cardiologist on site is really a big benefit to the pregnant patient and her family. It's as big a benefit as being able to get test results all in one day, like our one-stop clinic. If there's a defect of the heart found, we can, in collaboration on the same day, come up with what we think this is, what we think the consequences for the pregnancy might be, what a follow-up plan is, and start to formulate plans of where she should deliver, who should be present when she delivers, when she should deliver. And some of these babies we've actually been able to keep right here in our community. And so being able to get all of this information in a coordinated fashion is a very, very big benefit for the family. And on that same note of being able to provide services locally for our community is the development of our cleft lip and palate guidance program. The diagnosis of a cleft lip or palate can be devastating to a family. This is an ultrasound performed in our prenatal diagnostic clinic where you can see the likeness of the face is very similar to the baby after birth. The forehead, the eyes, nose, mouth. There's a little bit of a gap here in the lips. This particular cleft, which is a defect in the face, happened in the lip. It occurred in the alveolar ridge where the teeth come out. This one extended very far back, even into the roof of the mouth. So it's a very significant defect. It's really challenging for the family to be able to move on from something like this, and they need a lot of support. They need their families. They need to be able to deliver in their own communities. We had 4 cases of cleft lip and palate from the time that I came here to the time we had our first baby born here. 4 cases that we didn't quite have a program built up enough yet to allow these babies to deliver here. So in this situation, the trouble here is that the cleft, it can make it very, very difficult for the baby to feed. First we have to do is make sure that it's an isolated condition, meaning that this isn't coming hand in hand with cardiac condition, kidney problems, other chromosomal abnormalities. So we need genetic testing, we need thorough ultrasound, fetal echocardiogram. And once we think that this, and we know that this cleft is isolated, then we need to have specialists that can help this baby feed immediately after birth. And these babies can be born any time of day or night. And so we need people who are skilled in helping this newborn right after birth 24/7. So with the help of our administration, Stephanie Williams, nursing, occupational therapy, so many people coming together. Dr. McGuire in the neonatal intensive care unit, the nursing there. We were able to come up with a way that we can know that we can provide support for these babies. It takes a tremendous amount of effort, planning, but this can be done, and we did do it. This is the baby after birth. This is, the mother proudly provided us with these pictures for presentation here tonight. 1 month after birth, you can see where they needed to try and close the gap of the lip. If you look really, really closely, this baby actually has wires in the upper gum line, in the roof of the mouth, and slowly over time, this baby, it's come closer together. This is just 2 days ago I saw her. This baby's going to have surgery next Tuesday, actually. And so she's just so pleased and so happy with her experience. She was very, very grateful. Moments after birth, she was allowing pictures of staff with her baby, and she was just incredibly indebted to Washington Hospital for being able to put this program together for her and for many of the babies that are going to follow who have this. It's not an uncommon defect. It's about 1 in 700. Other services that we're providing locally for our community is the management of severe fetal growth restriction. Not always will mom's body support the pregnancy. Not always will the placenta provide enough nutrients for the baby. I always think of the placenta as the gatekeeper of the nutrients. Mom eats, the blood circulation hopefully gets to the uterus and to the placenta, and then the placenta needs to pass all that along down the umbilical cord. Doesn't always happen. We have a unique population here in Fremont, too, where this is more apt to happen. And these pregnancies need to be followed very, very closely. Oftentimes, these folks need to be basically followed at larger institution university centers for the expertise that it takes. What we need to do is be able to have exquisite timing of delivery. We need to balance the risks of continuing on the pregnancy in a somewhat hostile environment if the baby's not getting the nutrients that he or she needs, versus rescuing that baby from the womb and then risking the ravages of prematurity. So we really need to be able to follow and watch physiologically the condition and make that timing of delivery perfect. We have such a strong neonatal intensive care unit that we've been able to deliver multiple growth-restricted babies right here at Washington Hospital at 31, 32 weeks, and keep them here for weeks in order for that baby to grow up and finally be able to be discharged to home, where and also where the parents can visit the baby on a daily basis, multiple times a day, and not need to go into a large center far away and stay all day or miss days. So basically what we do, this is kind of a growth-restricted baby and the otherwise plump one. Sometimes they come as twins. And we've had those babies here too. But we look at the blood flow in the umbilical cord. We look at the blood flow in the baby's brain. We look at the blood flow in the uterine arteries to check the perfusion coming into the uterus. And we do this week after week until we know that it's time to deliver. And so for fetuses, and what about the mom? Some moms have arrhythmias, and pregnancy tends to trigger the arrhythmia. Even though they aren't having these abnormal heartbeats all the time, they can become more and more abnormal with the stretching of the mom's heart because she's accommodating a larger blood volume, and that stretches the cardiac conduction system, and before you know it, boop, they flip into an arrhythmia. These arrhythmias can be life-threatening. So we had a mom with a supraventricular tachycardia, and she needed to be monitored in labor throughout the labor, 24/7 until she delivers. And we didn't quite have our program up and running. She ended up delivering at a university center. And we said, well, let's get this up and running. So with a huge amount of effort, again, with a large support, we were able to pull this together. This requires input from intensive care unit, from nursing, from telemetry nursing, from emergency department, anesthesia, all multidisciplinary across disciplines. And we were able to get it together so that when we had a patient with a prolonged QT syndrome, which is something that is potentially quite life-threatening emergency, we were able to, at a moment's notice on a weekend, provide this monitoring during labor, and she required it for a full 24 hours after delivery. Another mom came in with supraventricular tachycardia. We planned this one. We said, it's okay, come on. Doors are open, deliver at Washington Hospital. And she did just that. Before I go on to share a couple of cases with you, I wanted to talk about another activity that we do quarterly. And this is our case conference, where we come together across institution, multidisciplinary, where we present a case in joint with Washington and UCSF, mom and baby. And then we have an academic discussion where we present the latest research so that we can be practicing evidence-based medicine for these interesting cases that we have. We've talked anything from steroids in late prematurity to help boost lung maturity, since we sometimes have to deliver these babies premature, sometimes even on purpose, and the guidelines, the controversies, the ins and outs, and how to do this, all the way to establishing our tranexamic acid use for obstetric hemorrhage, sometimes a life-saving medication that we have just started using in pregnant people over the last few months. So we've established that. Now, a couple of cases. And these are the kinds of cases that we find just really inspiring and keep us going. So I had a mom come in for a routine visit in the 3rd trimester. And we saw that the baby's intestines seemed a little bit too large. So this is an ultrasound of the belly of the baby all the way around. And inside, we have intestines. And if you look, not too subtle, we have some dilated bowel. This is fluid-filled bowel, full of stuff. Babies aren't supposed to have much in their intestines at this point. So I thought, wow, let's turn on some video here. And we can see that the bowel, the intestines are in motion, and they're peristalsing, squeegeeing the contents of the bowel down a little bit too forcefully, working a little bit too hard, and making no progress, a large backup. We diagnosed a volvulus in this baby. This is where the bowel twists. And because it's twisted, it can't empty its contents. And these contents just build up and build up and build up. Now, the tricky thing about volvulus, it's an on-again, off-again thing. And so I sent her up to UCSF to make delivery plans because this baby would potentially need surgery right after delivery, so it's suddenly a pediatric surgical case. Well, at that time, the bowel looked pretty good. So they said, well, let's have this baby deliver at Washington Hospital. And she did. The baby went all the way to term and was nice and healthy, fed, pooped, did the whole thing, had a normal X-ray. Things were good. Baby got to go home with caution. And so this is where we have our cross-collaboration with pediatrics out into the community. Our good Dr. Degoni understood. She actually read the ultrasound reports, and she understood that there could be something going on with this baby's bowel, even though the baby looked perfect on multiple checkups. So Dr. Degoni got very worried. She was planning on going to Lake Tahoe for the weekend, and she didn't dare leave this baby behind. So she instructed the mom very well that if this baby throws up, this baby needs to go to the hospital. Don't let them turn you away. Indeed, I had a seasoned mom. She had a kid at home already, and the baby threw up, and it wasn't just a little spitting up. So she trucks up to UCSF. She knew her way around. She had already been there. She knew all the players. And she said, my baby's throwing up. They said, it's okay. You can go home. She says, I'm not supposed to let me go home. So they admitted her for observation, and the baby did really well until about 2 o'clock in the morning, and the attending physician comes in to let her know things were good, and the baby threw up bile right in front of the attending physician. Well, an X-ray later, the baby was in the OR. Now, the key thing about this is, well, what if we didn't catch this right away? What if the mom did delay? You get 6 hours before the bowel dies off. If the bowel dies off, then the baby will lose almost all of it, huge segments in the operating room. And if that happens, and the baby manages to survive and not get septic, then the baby and child and adult will have lifelong problems. This baby was able to undergo surgery right away without a moment's hesitation, lost no bowel whatsoever, and was discharged to home just after a few days. And this baby is perfect. Awesome story. Keeps us going. What about the mom? We take care of them too, right? Yeah. So have a case of an arterial and a venous, a circulation abnormality in mom. So on the left, we have a normal situation. This is an ultrasound of the placenta, the womb. You can see a little baby in there. And then the cervix. This is the way out. I call that the trap door. This is what opens up at the time of delivery. And so this is all a normal situation. But if you zero in on the trap door in the patient that's not got a normal situation going on, we see huge blood vessels, huge abnormal blood vessels. You can see it going up. It's actually coming down, coming around, and taking a hairpin turn. That is obstructing. It's the trap door. If these vessels were to get disrupted, the mom can bleed and hemorrhage a lot. Incredibly rare. If you look this up in the literature, what you're going to find is a couple case reports, a few series in the literature of these acquired arterial venous malformations, and it's going to say that this is a source of abnormal bleeding, can lead to massive hemorrhage, and a timely diagnosis and proper treatment can markedly reduce the associated disease of mortality. So we said, oh goodness, what are we going to do about this one? Incredibly rare. So 17 weeks came along. We brought her back just 1 week later, and indeed we saw the artery. You can see these clearly going right into the vein, no capillary bed, terrible, dangerous situation, life-threatening. So we counseled the patient accordingly, and we really leveled with her. And so what do we do? You could maybe not make this. And so is this a pregnancy you want to continue? What are we going to put you in the hospital for 5 months if you want to continue? Is that what we would do? You would need to have immediate access to emergency services at all times. What do we do? Well, she was determined to continue the pregnancy. So sent her up to UCSF, where we placed a cerclage. What's that? That's a stitch in the cervix where you place a needle and just keep on going all the way around the face of the cervix in a circumferential stitch. And it's effectively a tourniquet on the cervix. And you cinch it down and leave it there. So we really had to have a coordinated effort. We sent her home. She was only 17 weeks. Sent her home, and really thought, what would we do if she came in bleeding? How do we watch? How do we monitor her? She came in every week for ultrasounds. Her OBs were totally on board with giving her weekly shots of progesterone to keep the uterus quiet, to make sure that she wouldn't go into labor on us behind our backs. And we made a plan. We were going to have a planned admission at UCSF starting at 28 weeks. So 28 weeks on the dot, she goes up to UCSF and she walks through the first floor entrance at UCSF, and I get a text. I give all my high-risk patients my cell phone number. And it says, I just got here at UCSF. I'm in the bathroom on the first floor hemorrhaging. What do I do? I texted her back, don't clean up, go straight upstairs. And then I texted all of my colleagues, and we sent out a huge army of doctors and nurses to check every bathroom, everything from all the women's hospital, the children's hospital, all on first floor, and we found her, took her upstairs. The bleeding sort of magically stopped. She was able to continue on the pregnancy. She had bleeding off and on. She stayed there from 28 weeks all the way to term. She delivered by cesarean section, has a beautiful baby. Sewed her up, took the cerclage out. She hemorrhaged, of course, right? And so we knew that this could happen. It's not that these vessels necessarily, sort of atrophied. So we were right there ready with interventional radiology. We were able to place some catheters into the iliac arteries and snake these little cannulas right up into the uterine artery, blow up the balloons, and stop the bleeding. She got a couple units of blood. That's all it was. And she did fine. Didn't even lose her uterus. So that's what we have, where we've been and where we've come to. Thank you.
Thank you very much, Doctor. That's very, very impressive. Very, very interesting. Over the last year or so, we've had reports of what's happening over there, but I'm stunned this evening. Really, congratulations. That's
Thank
a
you.
very, very, very impressive presentation.
Thank you so much.
Thank you for coming. Thank you. Our next item on our agenda is our consideration of minutes for July 2nd, 10, 22, and 24. Do I have a motion on that?
So moved.
Looking for a second.
Second.
Have a second from Jeannie. Motion and a second on those minutes to accept those minutes. Dee, if you'd take a roll call, please.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye.
Director Yee.
Aye.
Director Eapen.
Motion passes. Thank you very much. I see no oral communications this evening, so we'll move right to our written communications with Dr. Killaroo, our Chief of Staff.
Thank you, Dr. Stewart. We have the credential and action items. We have 2 physicians for initial 2-year appointment. Dr. Jet Liu, orthopedic surgeon joining Washington Township Medical Foundation, and Dr. Kavita Patel, pediatric hospitalist from UCSF, who's going to be working at the hospital here. We have nobody asking for temporary privileges or locum tenens. We have a number of reappointments for 2 years. Dr. Krista Amendola, pediatrics, Dr. Manesh Bhimani, emergency medicine, Melanie Castro, physician assistant with Dr. Barry Rose, Dr. Jing Dai, obstetrics and gynecology, Dr. John Engers, psychiatry, Dr. Muhammad Izzati, OBGYN, Dr. Jessica Ng, OBGYN, Dr. Ruan Kirangoda, otolaryngology, Dr. Elizabeth Kirkchan, OBGYN, Christy LaRoque, physician assistant for Dr. Kunwar, Dr. Stacy McDonald, OBGYN, Dr. Jayant Madarella, internal medicine hospitalist, Dr. Dimple Marwaha, DPM, podiatrist, Maylene Nguyen, cardiac perfusionist, Dr. Tam Nguyen, family medicine, Dr. Russell Nord, orthopedic surgery, Dr. Donald Pang, orthopedic surgery, Dr. Kaveri Patel, family medicine, Dr. Mark Penner, emergency room medicine, Dr. Marco Randoza, emergency room medicine, Dr. Catherine Saxton, family medicine, Dr. Cyrus Shariat, critical care, Dr. Robert Su, rheumatology, Dr. Javon Tang, infectious disease, Dr. Tay Win, internal medicine, Dr. William Wood, general surgery, Dr. Min Sain Wu, family medicine, Dr. Lansing Yang, pediatrics, Dr. Kevin Yi, internal medicine, and Dr. Stephen Zahner, family medicine. For 1-year reappointments, we have Dr. Neil Dickler, emergency room medicine, Dr. Desmond Erasmus, neurosurgery, Dr. Kareem Hussain, cardiology, Dr. Tirupati Reddy, cardiology, Dr. Gurchan Reen, cardiology, Dr. Bernd Schmidt, urology, Dr. Shaurab Sethi, gastroenterology. We have Dr. Millie Shah, who's deemed to have resigned. And in the transfer of staff category, we have Dr. Sonia Jurani, internal medicine hospitalist, Dr. Mark Laraida, internal medicine hospitalist, Dr. William McNutt, intensivist, Dr. Bhaskari Pila, pediatrics, Jennifer Satoriano, nurse practitioner with the emergency room department, Dr. Gurinder Singh, internal medicine hospitalist. For completion of proctorship and advancement in staff category, we have Jennifer Soteriano, nurse practitioner with the emergency room group, Dr. William Wood, general surgery. For new privileges request, we have Dr. Tang Lee, cardiothoracic surgery. For deletion of privileges, we have Dr. Desmond Erasmus, neurosurgery, Dr. Jessica Ng, OBGYN, Dr. Elizabeth Kirkjohn, OBGYN, Dr. Russell Nord, orthopedic surgery, and Dr. Gurchan Reen, cardiology. Conflict of interest statements were updated for Dr. Mimish Bamani, Dr. Neil Dickler, Dr. Russell Nord, Dr. Donald Pang, and Dr. Tirupati Reddy. Leave of absence for Melanie Castro, this is a physician assistant with Dr. Rose. And finally, we have resignations. Dr. Stephen Bardis, podiatry, Dr. Christopher Carpenter, pediatric hospitalist, Dr. Graham Hamilton, podiatry, Dr. David Hawley, radiation oncology, Cindy Liu, a physician assistant with Dr. Vandana Sharma, and finally, Dr. Seema Ricky, internal medicine.
Thank you, Dr. Todd. I have a motion on that.
So moved.
Second.
We have a motion and a second. Dee, if you'd take the roll.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye.
Director Yee.
Aye.
Director Eapen.
Thank you, Dee. That motion passes. Ruth, we're ready for the Service League report.
Okay, thank you, Dr. Stewart. Our Service League meeting was last week, and we were fortunate to have Kimberly Hartz attend our meeting with us, and the board was able to welcome Kimberly. The Service League board was able to welcome Kimberly as Nancy Farber's replacement as CEO. And Kimberly spoke to us about the patient first ethic, that will be continued, and that is something that is very high level for the hospital. And so the Service League and the volunteers certainly understand that. We will continue to move forward and carry forward the patient first ethic. Kimberly also talked to us about the changing times in the healthcare fields, and that what we know is that there's nothing certain right now. There are a lot of things that are going on, but we're here to help the hospital and do what we can as the Volunteer Service League to keep our organization moving forward. So we're very proud to looking forward to working with Kimberly as the new CEO for Washington Hospital, and we want to thank you for attending our meeting. And one other thing, we had a memorial with our last meeting. It was Margaret Tate. Margaret had served with the Service League for over 50 years. She was a founding member, and she said one of her first jobs was to work in a coffee shop, which some may remember, some may not, but it was on the first floor where the surgical waiting area is now. And that in the last year, she worked with the birth certificates, but Margaret was approaching 102, and she had served with us as a volunteer for 50 years. Thank you.
Hopefully we can all serve somewhere for that long, right?
That would be great.
Thank you very much. Our medical staff report, Dr. Killeru.
Thank you, Dr. Stewart. So as of now, we have 597 total members in the medical staff, 368 of whom are active.
Thank you. Thank you. We keep bouncing around that 600
Yes,
number.
that magic 600. Usually around July, August, we get a bunch of new applicants. So.
Okay. Well, we'll hope to stay above 600 sometime. Our hospital calendar from Kimberly Hartz.
All right, we'll start with the video calendar.
Past health promotions and outreach events. The 2019 Central Park Summer Concert Series, co-presented by Washington Hospital Healthcare System, kicked off on Thursday, July 11th. This free 6-week concert series is open to the public and is held at the Central Park Performance Pavilion on Thursdays from 6 to 8 p.m. Weekly attendance is estimated at 3,500. Washington Hospital will be providing health information during the 6-week concert series. On Thursday, July 18th, as part of the Women Empowering Women series, Dr. Victoria Leaphart, gynecologist, presented Gratitude and Well-Being. 10 people attended. On Sunday, July 21st, the City of Newark hosted the 6th Annual Newark Mariachi Festival. Washington Hospital was a co-presenting sponsor of this free cultural event. Representatives from Washington Hospital provided information of upcoming health programs and services available to the community. More than 500 people attended and 82 people visited the information table. On Tuesday, July 30th and Thursday, August 1st, Washington Sports Medicine hosted sports physical clinics for high school students. Each student received an assessment and physical to ensure they meet the California Interscholastic Federation requirements in order to play sports. Medical Director Dr. Russell Nord, along with other providers from Washington Township Medical Foundation, provided the examinations. Athletes also received orthopedic screenings by certified athletic trainers. Each athlete paid $20, which will be donated to the schools for sports medicine supplies. 95 students received sports physicals. On Thursday, August 1st, as part of the Diabetes Matters program, Alana Norden, registered dietitian, presented Dining Out Around the World. 17 people attended. The 2019 Music at the Grove Summer Concert Series concluded on Friday, August 2nd. Washington Hospital was a co-presenting sponsor. The concerts were held at Shirley Sisk Grove. Washington Hospital provided health information during the concert series. More than 300 people attended and 105 people visited the information table. On Saturday, August 3rd, Washington Hospital staff provided blood pressure screenings along with health and nutrition information at the Cat Williams Memorial Health and Back to School Fair, hosted by Solid Rock Community Services in Newark. Cat Williams was a longtime volunteer at Solid Rock Community Services, an organization based in Newark whose mission includes providing services to ensure the basic needs of life are met for families in Alameda County. More than 200 people attended the event and 32 blood pressure screenings were provided. On Tuesday, August 6th and Tuesday, August 13th, Melissa Reyes, RN, provided a two-part education series on stroke. Part 1, Stroke Prevention, educated community members about prevention, symptoms, and what to do if you are experiencing signs of a stroke. Part 2, Life After Stroke, was an overview on how to better understand your condition and how to move forward after a stroke. 41 people attended. On Saturday, August 10th, Washington Township Medical Foundation hosted a special health fair at Nakamura Clinic in Union City. This fun and free community event included glucose, cholesterol, blood pressure, and body mass index screenings, and an opportunity to talk to experts on health insurance, diabetes, nutrition, heart disease, and stroke. More than 70 people attended the event, and 59 screenings were provided. On Monday, August 12th, the Women's Health Strategies for Wellness series began with stress management and self-care, presented by Dr. Seema Sehgal, psychiatrist. This 6-part education series explores diseases and mental health challenges common to women and outlines strategies of prevention and well-being. Participants are not required to attend every class. 27 people attended. Upcoming health promotions and community outreach events. On Thursday, August 15th, as part of the Women Empowering Women series, Dr. Victoria Leapart will present Don't Let Arthritis Slow You Down. On Wednesday, August 21st, from 6 to 8 p.m. at the Washington Township Medical Foundation Newark Clinic Conference Room, Dr. Victoria Leapart will present Laugh Without Leaking, Understanding Female Urinary Incontinence. On Monday, August 26th, from 6:30 to 8 p.m., as part of the Women's Health Strategies for Wellness series, Dr. Vanessa Wilson, Internal Medicine, will present Depression, More Than a State of Mind. On Thursday, August 29th, from 3 to 5 p.m., Doctors Natalie Tett and Shekhar Srinivas will present Learn the Signs and Symptoms of Sepsis. Do you have pain or discomfort in your legs or feet, difficulty walking any distance without pain, or color changes in the skin of the feet? It may be peripheral vascular disease, PVD. If left untreated, patients with PVD can develop serious health problems, including heart attack, stroke, renal artery disease, and amputation. Diagnosing PVD can be as simple as performing a painless, non-invasive Doppler ultrasound investigation of the patient's leg circulation. On Saturday, September 7th, from 10 a.m. to 1 p.m., Washington Hospital will host a PVD screening event. This free screening includes a Doppler study and an interpretation of results. This event is co-sponsored by Fremont Bank Foundation. Pre-registration health questionnaire is required. Call 800-963-7070 to schedule your appointment. On Monday, September 9th from 6:30 to 8 p.m., as part of the Women's Health Strategies for Wellness series, Dr. Stacy Berry, Obstetrics and Gynecology, will present Women's Health Through the Years, Screenings Key to Aging Well. Bay Area Healthier Together. Washington Hospital's partnership with ABC7 continues to provide health-related information and education through on-air programming and on BayAreaHealthierTogether.com. The featured topic during the month of July was wound healing, featuring Dr. Prasad Kilaru, plastic surgeon and medical director of the Washington Center for Wound Healing and Hyperbaric Medicine, plus articles on common types of chronic wounds and what you need to know about hyperbaric oxygen therapy. The Washington Hospital Healthcare Foundation Report. On Saturday, October 12th, the Washington Hospital Healthcare Foundation will host the 33rd annual Top Hat Dinner Dance. The trustees of the foundation have designated the proceeds from this year's Top Hat Gala towards the support of the Washington Hospital Women's Center with the purchase of 3D mammography equipment. This cutting-edge technology has been proven to produce clear diagnostic images, making it easier for physicians to detect abnormalities, reducing instances of false positives and unnecessary biopsies. The co-chairs for this year's dinner dance are Fremont Police Chief Kimberly Peterson and Drs. Rohit and Seema Sehgal. The co-chairs thank the following returning sponsors: Fremont Bank, Professional Home Care Associates, Saw Orthopedic Associates, Gonzalez and Kozenchenko, Masonic Homes of California, Palo Alto Medical Foundation, and Royal Ambulance. To reserve seats at Top Hat or to inquire about sponsorship opportunities, please call the Foundation at 510-818-7350. The Washington Township Healthcare District Board of Directors Report. Washington Township Healthcare District Board members attended the State of the City address delivered by the Honorable Carol Dutra Vernacci, Mayor of Union City, on July 25th, and the Masonic Homes of California's Luminary Caregiver Awards dinner on July 27th. Washington Hospital Employee Association, WIA. WIA's Back to School Drive Fill a Backpack Challenge was a huge success. WIA proudly donated 80 backpacks, $135 in gift cards, several bags of school supplies, and 2 boxes of personal hand sanitizers. These donations were presented to representatives of SAVE and Abode. On August 3rd and 4th, WIA held their biggest fundraiser of the year. During the Fremont Festival of the Arts, employees requested a $5 donation for festival attendees to park at the Washington West parking lot. The event raised $3,974. Proceeds will benefit charitable projects and organizations in the district. Washington on Wheels, WOW Mobile Health Clinic. The Washington on Wheels Mobile Health Clinic, WOW, is a mobile medical unit providing quality healthcare services primarily to uninsured and underserved district residents. WOW brings Washington Hospital's commitment to patient-first care to clients throughout the district. Despite being out of commission for multiple days due to the need for repairs, during the month of July, the WOW mobile unit served community members at the following locations: the Fremont Family Resource Center, the Union City Family Center, and the Viola Blythe Community Services Center in Newark. These community partners provide social services to families in need and the homeless population. The total number of community members receiving health care from the Washington on Wheels Mobile Health Clinic during the month of July was 12. Internet and social media marketing. Washington Hospital's website serves as a central source of information. The hospital's employment section was July's most viewed webpage with 39,775 views. Washington Hospital has an active social media presence. Through these channels, we update the community with news on events, services, and patient care. Connecting with our community through social media continues to grow. For example, our Facebook audience has grown by 20% over the past 12 months. In July, our most popular social media post was focused on a cancer patient from San Jose who praised the treatment at our UCSF Washington Cancer Center. Users can find us on Instagram, Twitter, and Facebook at Washington Hosp. InHealth, Channel 78. During the month of July, Washington Hospital's cable channel 78 InHealth aired new programming, including a Diabetes Matters program called Diabetes Conversations and the July Board of Directors meeting. For more information on any of the programs mentioned, visit WHHS.com or call 800-963-7070. And please follow us on Facebook, Twitter, Instagram, LinkedIn, and YouTube.
All right, I would also like to let you know who is the August Employee of the Month, and it is John Bell, who is our desktop support lead and supervisor. So when it comes to needing help with a computer problem, calling on John and his team is a sure thing. In 2012, John began working at Washington Hospital as a contract employee, assisting with the Epic rollout. His work was so meticulous that he was invited to join the team full-time in 2014. John thoroughly enjoys his work. He describes each computer challenge as a puzzle that needs solving. John tackles each situation knowing that he not only needs to fix the problem, but also needs to understand what caused it. That's how to prevent the problem from reoccurring. This is one of the reasons coworkers admire John's amazing troubleshooting skills. John believes that his team plays a small part of every hospital project. Where there is a patient to serve, a computer is somehow involved, and that's how the team contributes to the patient-first ethic. We help others do their jobs so they, in turn, can assist patients, says John. John's manager, Director of IS Operations, Greg Dillenbeck, describes John as personable with an easygoing attitude. Both John and his high school sweetheart and wife of 24 years, Marie, are sports fans. They are season ticket holders to the Warriors and attend many games. Living in Union City, they have raised 3 boys, Aaron, 24, Noah, 20, and Landon, who is 11 years old. John and Maria enjoy trips with their sons and weekend getaways to Disneyland. When honored as Employee of the Month, John is appreciative, but quick to point out that it really is all about his team. Without employees like John Bell, the jobs of those who directly provide patient care would be much more difficult. No matter how complicated a problem, John will find a way through it. You can bet on that. So.
Thank you. Thank you, Kimberly. We're now ready for our lean report. That'll be given by Carolyn Crosby. Do you have a?
Yeah, I'm gonna. We have developing a daily management system in OB, and so we actually have 2 presenters tonight. The first is Carolyn Crosby. Carolyn Crosby received her first nursing degree from Maloney College. Following graduation, she entered into a new grad program at Lucille Packard Children's Hospital and began her career on the pediatric solid organ transplant and cardiovascular unit. In 2007, after establishing a solid nursing foundation at Packard, she was drawn back to Washington Hospital to serve the community where she grew up. Since that time, Carolyn has had an active role in the pediatric department, most recently assuming the role of pediatric care coordinator. Over the past few years, she completed her BSN and MSN in leadership and management from Western Governors University. She has been managing the Lean Kaizen initiative for the Birthing Center since 2018. I would also like to introduce Kelly Franklin. She just recently joined Washington on July 1st. Kelly began her healthcare career as a CNA while attending nursing school in Tacoma, Washington. After graduation, she spent 2.5 years as a pediatric nurse prior to transferring into her dream job in L&D. Most of her career has been in high-risk obstetrics as a staff nurse, a charge nurse, and a manager. She also spent almost 5 years as a high-risk maternal transport nurse. In 2015, she obtained her BSN, and in 2017, her MSN in nursing leadership from Grand Canyon University. A few years in case management and quality solidified her love of OB and need to return. She has worked in Washington, Arizona, and Las Vegas before moving to the Bay Area, and we welcomed her in July.
Great.
Thank you. Sorry. A little background. The obstetric unit started their Kaizen Lean journey in September of 2017. The journey consisted of 5 workshops, which included 39 OB staff and 13 doctors who were all identified as good candidates for lean leaders and educators. The workshops included the value stream mapping, 5S, standard work, problem solving, and daily management. Improvement activities conducted included all of those, with the biggest focus being in daily management systems using leader standard workflow, visual management, accountability, and problem solving. What is daily management? It's a fact-based approach to unit management where staff members measure and evaluate progress towards plans and unit goals. The unit goals are linked to organizational requirements and provide for daily problem solving and learning. They allow us to identify the problems and control key processes in improving. These are some of the characteristics of it. And our biggest support comes from our frontline daily staff. Daily, we huddle at the start of each shift. It takes 5 to 10 minutes. And our meetings include information on daily work plans, key metrics, discussion of barriers, staff-generated improvement ideas, as well as staff recognitions. These huddles enable awareness and occur at our visibility board, as you can see up here from the pictures. They use visual displays that correspond with our metrics, and the run charts are manually updated on a daily basis so that we're able to see in real time how our problem solving is going and what we need to focus on. As a new leader here, it has really allowed me, it's been really easy to come in under this type of a program and see what quality initiatives there needs to be focused on and how we can work to solve those issues. The frontline staff goals are purposely linked to unit leadership goals, and as in the same example, we're using a Pareto chart to drill down on things that are impeding our timely discharges and getting our patients out by 11, some of our biggest work. Carolyn has been one of our biggest champions of this whole process, and I'll let her go into more detail about the specific metrics and how we're meeting them.
Hello, my name is Carolyn Crosby. I am a nurse in pediatrics and obstetrics. Thanks for having us. So I'm going to start here as leaders, as teachers. So we understand that people learn in a variety of ways, and so we like to present information in multiple methods. So formal methods might include your traditional in-service, and then informal methods might include something like our lean connection board we have up there that we use just to kind of capture as many people as we can. Our leadership also encourages staff to be problem solvers. So we use our improvement ideas as a way to encourage our frontline staff to participate in troubleshooting and problem solving because they are our experts. So let's take a closer look at one example of problem solving on the front line. We were consistently having outstanding tasks to complete on day of discharge, and this was affecting both our discharge time and the flow for our patients. So following a Kaizen workshop, we enlisted the help from our EPIC team and created a discharge tracker, as you can see. Before implementation, we established that about 53% of our patients had outstanding tasks to be completed on the morning of discharge, such as like maternal immunizations or the birth certificates. And after implementation of our discharge tracker, we're now easily able to identify what needs to be done, really starting on admission, so we can start getting those things done and reducing items that are outstanding on day of discharge. For the past 2 months, our data has shown a reduction to 28% and 32% respectively of patients with outstanding items on morning of discharge, so we are headed in the right direction. Now I'd like to shift gears and talk about our pre-admission intake process. Having a baby is such an intimate experience, and we really strive to align our care with the patient's desired birth plan. Now, I don't know if any of you have been in labor or had the opportunity to support a woman in labor, but when a woman is managing her contractions, it's not really a great time to converse. So what we did was we created our pre-admission process. And so during this one-on-one appointment, the patient sits down with our admission nurse and they discuss their wishes. They receive a personal tour of our unit. They begin to receive their ongoing education, and they have a chance to ask questions before they arrive to the hospital. This also is our opportunity to really establish rapport with our patients and really show them that we're excited and honored to be able to be part of their birthing experience. Following a Kaizen workshop, our baseline and goal were established, and through direct outreach to our obstetricians in their offices and utilization of features in MyChart, we've consistently been improving our percentages. In the month of July, approximately 95% of our eligible term mamas were able to come in and meet us before they delivered. And I think it's worth noting that Dr. Sharma, for the past 2 months, has had 100% of her patients come in and sit down with us before they came. So that's pretty outstanding. So out of our 5 Kaizen workshops, 1 was dedicated solely to communication. Now, we all know the importance of communication. Here at Washington Hospital, we value it so much that we dedicate time during orientation to teach our evidence-based team steps approach. And I would venture to say that any debriefing that I've ever been a part of or attended, communication is always identified as the biggest area for improvement. So we jumped at the opportunity to focus on how we communicate during handoff, specifically from the labor to the postpartum phase of care, to improve outcomes and care provided for our patients. With primary focus on transfer of knowledge related to pertinent data, we again enlisted our friends over at Epic and came up with an OB handoff tool. And in the true lean spirit, we used the PDCA process, and our 3rd version of our handoff tool has proven to be quite useful. You can see the top graph. The number of missing items at handoff was assessed to be about 75, maybe close to 80% initially at baseline, and there has been a nice steady downward trend. In the bottom graph, you can see our efforts to have patients discharged by 11. As mentioned before, we implemented our discharge tracking tool in Epic, and while this metric has probably proven to be our most challenging, it's coming down, so we're headed in the right direction. We'll celebrate small victories. We began to utilize our tools that we've developed in the lean processes to really identify what's going on here. So initially, once we got everyone comfortable just tracking whether they were going home before or after 11, we then kind of drilled down into the individual causes and tried to figure out things that we could fix. So initially, medical records, the birth certificate was the biggest problem. People don't have names. It's such a thing to commit to. So it always delayed our discharges. So we started implementing as part of our pre-admission process that the nurse shows them the forms and starts kind of working on things that they can fill out ahead of time. And then we also worked really closely with our medical records department, and I'm pleased to report that in the month of July, only 2 patients were out after 11 as a result of the birth certificate. So that has been a really huge improvement for us. Staff recognizing staff. So staff engagement is paramount to our lean success. Monthly surveys assist us engaging our staff's needs and really just seeing kind of where they are at. We recognize when our staff members go above and beyond and also encourage peer recognition. Every month we hold a drawing for our stars, and we raffle off a prize. So there's incentive to also kind of be a team player. These practices directly link to the Lean Foundation principle for respect for people. And to conclude, we'd like to reinforce that the Lean process is actively used by both frontline and leadership staff in our OB department. We measure our progress by means of our ongoing successes, our handoff tool, our changes in Epic, our pre-delivery appointment, and we also celebrate our continued dedication to the Lean principle of Hansei, our reflection and practice of continuous improvement. And I'd like to see if anybody had any questions.
Appreciate your presentation. Are there any questions from the group?
Progress.
It's nice progress.
We're trying. Thank you.
Thank you.
It's good stuff. Thank you very much. We're now ready for our quality report from Mary Boron.
Good evening. Thank you. Tonight I'm going to be presenting our quality dashboard for quarter ending June 19 this year. So starting off with our core measures that are electronically abstracted from the chart and sent directly to CMS. We're looking at the venous thromboembolism. This is basically preventing patients from, what are we doing in the hospital to prevent patients from developing clots? They break it into two groups. That would be the med-surgical patients and then also our patients that are in intensive care while they're here. And overall, we have done well. We've had the patients outside of ICU had a 95% compliance rate for putting into place all the measures that we do to prevent clot development, and 100% in critical care. Again, we're waiting for a benchmark to come back on this so that we can see where we are compared to the rest of the nation. Stroke overall did extremely well this quarter. There was straight across the board, there was 100% compliance for the stroke cases that were abstracted and sampled and looked at to make sure that all those patients got the right medications to prevent the development of clots while in the hospital. They right education, and this is a face-to-face, one-on-one education so that each one of those patients are seen prior to discharge to sort of go over what they need to watch for when they go home and give them information and background on stroke and some community resources. Same with being assessed for rehabilitation. All of these patients were seen and assessed for whether or not they need rehabilitation while in the hospital and, again, following up outside of the hospital after discharge. So that's a great reflection of what the stroke program is doing. Moving into our infection prevention indicators, our central line associated bloodstream infections have continued to be higher than expected by the CDC for institutions that are like ours and the same size and type of ours. And in this particular quarter, for CLABSI, we did have 5 infections, and so that was 3 infections in critical care and 2 outside. I'm sorry, 3, not 5. 3. And the CDC predicted that we would have 2. So we are 1 above that, and that will again put us this quarter for over the benchmark. So what we're doing with this is recognizing that it's consistently been above the national benchmark. Is we have a group of a multidisciplinary team. It's mostly looking at are the central lines that are in place here every day medically necessary? And if they aren't, we need to get them out sooner so that the patient is not at risk for developing a central line bloodstream infection. What are we doing to prevent the development of it? Meaning, so how are we doing our dressing changes to the central line? It's things like hand hygiene, approaching and accessing the line only when you absolutely have to give a medically necessary medication. Things of this are really a bundle approach, which is what you need to prevent CLABSI from developing. So we've, nursing is especially looking at this, looking at things right down to, are we using the best kit we could be using? What are we looking at for hand hygiene? Doing direct observation for our CLABSI bundle. So taking that very seriously, and we're hoping that we'll see better numbers moving forward. Again, it was just 1 extra case, but that's that one extra case makes a big difference if you're the patient, right? So we are looking at that closely. Hospital-acquired MRSA. So again, this is a multi-drug resistant organism, difficult to treat with antibiotics. We did have one, and what this means is that if the patient has been in the hospital for greater than 3 days and anything that's done with a blood test that could show that they have MRSA is now considered a hospital-associated infection. It's a surveillance measure. It doesn't necessarily mean that the patient did not have it upon arrival, but we didn't detect it within the first 3 days, so therefore it's considered hospital-associated. So these cases are actually looked at in a root cause analysis with Dr. Martin to see, was there anything we could have done to prevent that, and that's spread by direct contact. So again, we're looking at that. It just put us like right at the number of expected from the CDC. So not better than or worse than other hospitals of our size and type. Same thing with vancomycin-resistant enterococci infections, otherwise known as VRE. VRE, we've done overall well on 5 out of the last 6 quarters. We have not had a VRE infection. This is actually a predicted number of infections. We've been able to stay far below. So it's the same thing that you sort of do to prevent MRSA with the hand hygiene and being careful about isolation and not spreading infections in the hospital. Those interventions have been working well to prevent VRE. C. diff, as you know, we have had a lot of continued interventions in a bundle format to stop the spread and to improve the identification of C. diff. And so, again, this quarter, luckily, we have remained below the national average of what's expected. And in this particular quarter, we did have 8 C. diff infections, and the number predicted were 10. So still, we want to, of course, get this down to even lower than what's predicted. So it's not that we're looking to stay in comparison to the average. We want to be better than the average, but we are continuing to go in the direction of keeping those less than expected. Again, it's a combination of how we treat patients with antibiotics here, EVS and how they work with us to make sure that the rooms are cleaned appropriately, hand hygiene, all these things that can prevent the transmission based. But I think one of the key factors in this is that we are also testing appropriately. We just do not test straight across the board. The CDC recommends that you use a actual flow chart and identify patients that are at risk, and we've been revamping that flow chart and taking it to the medical staff and nursing and looking at it all as a group to say, are we testing appropriately? So that way we're not over treating patients who don't necessarily need treatment for a symptomatic C. diff infection. So I think we've done a lot to make sure that process is working out valid, and you can see it in the outcome data. Surgical site infections, overall, we have, as you can see, steadily done well on making sure that patients do not have any surgical site infections related to their colon surgeries. This quarter, we did have one. Even one goes through the peer review process. The medical staff is able to look at that case, follow it from the beginning of admission to the identification, and look and see if there's any chances for improvement in a practice level and in a process level. And that's, like I said, done through the peer review process with an infectious disease doctor who also looks and gives feedback on these cases. So just right at number of expected from the CDC we were at. Surgical site infections for abdominal hysterectomies, overall continue to do really well with that. We did not have one, so we were below the number of predicted infections. Our nursing sensitive indicators, the one we're focusing on here, is the inpatient falls with injury. Of course, any fall is something that we need to look at, which is defined as an unplanned descent to the floor. And but this one in particular looks at injuries, and we're just slightly above the national rate on this. And it doesn't take much to put you there. Out of 14,000 patient days, this is actually one fall resulting in a skin tear abrasion, which is actually considered an abrasion. So minor, but again, need to look back and see and what happened and what led up to that. And that's really what the Falls Committee does, and increasing the rounds and the frequency that patients are seen, and having the group huddle right after that happens so we can hear real-time quick information on things that we may have think led up to it. This patient was identified as high risk, which is actually a good thing, because it means that this is somebody that we recognize had the risk and we were working closely to prevent it. And but there was a fall and a slight injury. The Joint Commission National Patient Safety Goals overall are doing really well. Handoff communication that was directly observed throughout the hospital in various areas. We did better than the Joint Commission National Standard, which is 90% of the time, and in all direct observation of handoff communication, 100% of the time. We did see that those elements were all met. Patient identification, same thing, 100% compliance for this quarter, making sure that all elements of patient ID were verified and completed on the direct observation process that we do at random in the hospital. And the last one, procedure time out, is actually, we've had some problems in the past where the procedure timeout did occur, but we didn't have quite every element documented. They've done a lot of education on that, and we go back and even sample and look at that and make sure it's charted appropriately. This quarter, that met for 100% of the time. Hand hygiene, we had some times towards the end of 2018 where, you could see we had a dip in compliance. So we've looked, especially at the beginning of this year, on increasing basically the people doing the surveillance, the people educating people, any discipline, physician, nurse, anything, that when they're identified as not washing their hands at the right time and the right place, they're immediately approached. And that's this national standard for safety. So if you recognize an unsafe practice, you should stop it and intervene immediately and do education around it. We've done that. We've seen some increased compliance. The national documentation of what you see on average in a hospital is around 70%. Joint Commission is asking for something closer to 90%. And in this particular case, for our quarter, was 84%. So it's gone up and is holding steady for the last 3 quarters, but we still want to continue to improve on this. And patient safety is looking at some initiatives around that right now. Readmission rates. Before I get into readmission rates, I want to talk a little bit about the collective interventions that we're doing for every disease state. CMS is looking at, and has been for years, the patient populations that are high risk for being readmitted to the hospital. So this is heart failure, pneumonia, AMI, and COPD. They also look at patients who've had knee and hip replacements and patients who've had a cardiac surgery, otherwise known as a CABG. And our focus area has been the disease states that we think we're at the most high risk for, and that we need to be managing these patients with chronic illness better and build a strong infrastructure around doing that. So we're sort of revamping that program, and we have a steering group. We have every discipline represented, who is, we're actually meeting on more frequently than a monthly basis to see what we can do to really look at readmissions and make sure that these patients are being identified early in the hospital process and that they're getting national standard interventions prior to discharge. These are things like follow-up phone call after they leave the hospital, making sure a case manager sees them, making sure a social worker sees them. If they need to be seen by respiratory therapy, they are and working with the medical staff on what we can do to make sure that their medications are managed appropriately. So, but I want to get into the rates. In all, with every disease state, we're a little bit above the benchmark. Going into pneumonia, for example, ours for this quarter was 22.2. That puts the national benchmark for pneumonia is closer to 16.7. So 20 out of 90 patients came back. Those are the patients that we're looking at, like, why did they come back, and what could we have maybe done to help them manage their pneumonia after they left the hospital. And but there's also the factor that of these 20, not all of them came back for respiratory illness. In fact, in this case, it was actually 50%. doesn't matter to CMS, it's all-cause readmission, and I think we've had that discussion here many times. But Medicare also looks at the AMI. Another word, obviously, is put that is to have patients who have had heart attacks. This population is typically in the 10 out of 30 that came back, which put us above the national benchmark. With actually 33% of patients came back. And CMS overall in the nation, we'll see closer to 16% for what CMS has predicted should be the average of percentage of patients coming back. Again, AMI tends to be patients that may have other chronic illness that brings them back, and most of this could be diabetes, other things that they're managing in addition to whatever cardiac issue they had. So AMI is another one that we're doing the best that we can with, but like I say, it's we have identified that really what maybe we should be looking at closer in this population is maybe even how diabetic management, things like that. So heart failure is a little different. 18 out of 79 came back this quarter. So that puts our readmission rate at 22.8. National benchmark is 21.7. I think one of the reasons why this is tended to do better is because it was one of the first disease states that we focused on, and all these patients are getting calls when they leave the hospital, and we're trying to make sure that they're seen by their primary care doctor if they have one within 7 to 14 days. We're doing other interventions around that in the committee that I spoke about. What I think we've learned mostly about heart failure recently is that the social determinants and the chronic illness and the situations people deal with after they leave the hospital with heart failure are very complex. It's hard to understand all of your medications, right? And sometimes not everybody can get to their PCP afterwards. And there are a lot of things that lead to these patients really needing day-to-day support. And so we've had a clinician with 30 years nursing experience calling these patients, and I can tell you we're finding great information that we'll be able to share with you later on, and trying to make interventions that are will make more of an impact and give them more support in the community, and even working with them if they go to a SNF, and we're building relationships with the SNFs and seeing sort of what their challenges are in that when they are managing heart failure patients. So that's one we'll continue to focus on more, and you'll be hearing a lot more about. So those are the disease states with readmissions, and like I say, I hope to see those coming down after we get a stronger infrastructure and some interventions moving forward.
Thank you very much, Mary. Okay. Any questions from the board? Great.
Thank you.
Thank you, Mary.
Thank you. Finance report, ready for Chris Henry.
Things sorted out here. So tonight we'll be looking at the operational and financial results for Washington Hospital for the last month of our fiscal year, June. Moving in our operating indicators, the average daily census for the month came in 5.1 lower than expected in the budget at 174. Admissions came in at 1,024. We had anticipated 1,097. Patient days for the month came in 154 below budget at 5,220. Outpatient observation equivalent days for June came in 21 above the budget at 160. And our average length of stay for the month came in at 5.08. That's a bit lower than we've seen in the last several months. We had anticipated 4.9. Looking at utilization, case mix index for the month came in at 1.490, pretty close to the 1.476 that we had budgeted, a little bit higher. Deliveries for the month came in lower. Again, that number continues to be volatile from month to month. We had 118 deliveries in June. We had expected 147 in the budget. Surgical cases for the month came in one above the budget at 375. That includes our joint replacement cases that were 6 above budget at 151. Neurosurgical cases came in at 21. We'd expected 27. Cardiac surgical cases, we had 7 in the month. We'd expected 10. Cath lab procedures were, the balance of that variance was rounded out in general surgery. Cath lab for the month came in pretty close to budget, just one procedure below budget at 341. We had 7,294 outpatient visits in the month, so those numbers continued to be high. We'd expected 7,084. In the emergency room, came in 234 visits below budget at 4,487. We'd expected 4,721. Quick look at the cath lab activity. Cardiac activity made up the bulk of the activity for the month. Peripheral vascular was lower than we've seen. We did have one of our major peripheral vascular physicians out on vacation for 2 weeks during the month, so we're seeing the impact of that here. Non-vascular interventional radiology made up 23% of the activity for June, and finally neurointerventional radiology at about 2%. Looking at productivity, productive FTEs for the month came in 10.6 below budget at 1,361.1. We saw 192.7 non-productive FTEs in the month, giving us total FTEs that landed 24.5 below budget at 1,553.8. Our full-time equivalents per adjusted occupied bed, which is our productivity measure, came in 0.46 below budget at 6.18, so a pretty good performance there. Moving into the financials, as always, we'll look at our Governmental Accounting Standards Board presentation first. This is the presentation we're required to use for our audited financials. Total patient revenue for the month came in a little over 3% below budget at $184,472,000. Our deductions from revenue for the month came in below budget at 76.72%. We'd anticipated 78.8%. We had a little help there. Our contractual allowances for the month, while our payer mix was not favorable, we did have a number of items that helped that out. About $2.9 million in positive adjustments to our contractuals. About half of that was the result of a favorable result from the 2017 cost report audit. So we picked up $1.4 million there, and the rest of that was just coming from year-end adjustments to our contractuals. We this time of year really go through them with a fine-tooth comb and felt we needed to bring them down a little bit. Also helping those numbers was our provision for bad debt and charity. For the month, private pay made up 1.4% of our total gross revenue. We've been seeing those numbers pretty close to 3 or higher during the year. So we picked up another $1.8 million there, really helping that things out there. So we ended the month with net operating revenue almost $3.6 million above the budget at $44,767,000. Operating expenses for the month came in a little under $1.4 million over budget at $40,836,000. We had several drivers there. And although our FTEs were below budget, our salaries and wages actually came in a bit above budget. We did do an at-risk comp action for the CEO. There was a timing difference there, and when we had anticipated that coming, and we used higher than expected overtime to cover the activity in the month. Generally, June is one of our lowest months of activity, and we had been running below budget really all year and expected that activity to drop. When it stayed up, I think the labor market here gave us a little bit of a hard time picking up nurses to cover the folks, so we ended up having to fill in with a little bit of overtime there. Benefits for the month were higher than expected. Again, we continued making our pension adjustments that we've seen the last 6 months there. Our supplies were about almost $300,000 above budget. That was really driven by prosthesis. We had a higher number of bilateral joint replacements in the month. and those prosthetics are pretty expensive, so that drove that number. And those were really the main drivers there. So we ended up June with an operating bottom line almost $2.2 million higher than budget at $3.931 million. Non-operating income for the month actually came in with a $395,000 loss. We did have a $552,000 pickup on our investments from the financial markets, but we did recognize the bond issuance costs on the refinancings we did in June. Those refinancings were not anticipated in the budget, so those were we have to recognize them in the month where we go to the market, and that's what's happening there. So we ended up June with a total bottom line of $3.5 million, a little bit more than that, against a budget of 1.7. So pretty good month financially there. Quick look at our Financial Accounting Standards Board presentation. This is a presentation that shows some adjustments that might be made by the financial markets when they look at our numbers. We move our interest expense out of non-operating income up into operating expenses. We end up with operating income as a result of that adjustment of $3,083,000, almost $3.1 million. Other adjustments we make to that non-operating income is FASB does not recognize the tax revenue that supports the debt service on our GO bonds, nor do they recognize that unrealized gain on our investments. So we end up with non-operating income almost the same as it was in the GASB presentation, was showing a $367,000 loss. We'd expected to pick up $614, but again, that's still carrying that $930,000 bond issuance cost. So we end up June from a FASB perspective with a total bottom line a little over $1.2 million higher than budget at $2,716,000. I'll run through EBITDA quickly. Earnings before interest, taxes, depreciation, and amortization. This presentation gives us kind of an idea of how much cash we're generating in the operations. We do that by pulling out non-cash items, the biggest one of those being depreciation. We've discussed the nature of depreciation in the last several months. So we pulled depreciation away from our operating expenses to come up with an EBITDA number of $8.6 million. And if you look down into the non-operating section, we separate out our interest expense, and that shows that our non-operating activities generated another $1.6 million in income. So in total, a little over $10 million in income that can be utilized for that debt service and also to fund the continuing capital and operating needs of the district. So EBITDA numbers are pretty strong in the month. And that's June. Are any questions on June activity?
No questions. We'll go into the operations report.
Right, so I am going to present July 2019 numbers. I will have to just say, if you were around the hospital during July, you will see that we had a very busy month, and not only you'll see that there were a number of areas that we were above budget, but also if you go back to July of 2018, we were actually above those numbers. So as we'll see as time goes on, but we did have a very busy month. So to begin with, right, here we go. Gross revenue of $196.3 million for July was above budget by $25.2 million, or 14.7%, and above July of 2018 by $44.4 million, or 29.3%. As you can see, inpatient gross revenue of $135.2 million was above budget by $17 million, and $28.4 million above July of 2018. And also outpatient gross revenue of $61.1 million was above budget by $8.2 million, or 15.6%, and $16 million above July of 2018. Looking at the major drivers of revenue, cath lab procedures were above budget by 37, driving cath lab revenue up by $2 million. Inpatient days were above budget by 780, driving room and board revenue up by $5.7 million. Surgical services procedures were above budget by 51, driving surgical services revenue up by $6.2 million. The higher level of inpatient and outpatient activity drove ancillary services revenue above budget by $10.8 million, or 14.1%. In terms of our key census statistics, average length of stay of 5.29 was above the budget of 4.99. Observation days, outpatient observation days were 11, or 6.6% above budget at 177 days. An average daily census of 176.9 was above the budget of 151.7 by 25.2, or 16.6%. And again, the average daily census was 39.5, or 28.7% above July of 2018. Looking at our admissions trends, our admissions were 79, or 8.4% above the budget at 1,022. Admissions for the month were 103 above July of 2018. Major drivers of the admissions variance: inpatient surgical services that were above budget by 10, inpatient cath lab procedures were above budget by 8, and inpatient medical admissions were above budget by 61. Our patient days of 5,484 were above budget by 780, or 16.6%. And these patient days for the month were 1,226, or 28.8% above July of 2018. Our surgical trend, total surgical cases in July were 416. Of 416 were above the budget of 365 by 14%. And surgical cases were 86 above July of 2018. Inpatient surgeries were 10 above budget at 247 and 6 above the July 2018 volume. Outpatient surgeries were 41 above budget at 169 and 80 above July of 2018. Our surgical activity, our neurosurgical procedures were above budget by 2, or 8.3%, and they were 10 above July of 2018. Cardiac surgical procedures were also above budget by 2, or 20%, and they were 2 above July of 2018's volume. General surgical procedures were above budget by 18, or 9.1%, and they were 45 cases above the July of 2018. And then joint replacement surgeries were above budget by 29, and they were also 29 above July of 2018. Looking at our cath lab trend, cath lab procedures for July of 411 were 37, or 9.9% above budget, and 93, 29.2% above July of 2018. Inpatient cath lab procedures were above budget by 8, at 4%, at 209 and 64 above July of 2018. Outpatient cath lab procedures were above budget by 29, which is 16.8%, and above the prior year by 29. Looking at our cath lab activity, our neurointerventional radiology procedures were below budget by 2, or 22.2%, but 2 above the July 2018 volume. Cardiac procedures were above budget by 6 and 40 above July of 2018's volume. Peripheral vascular procedures were above budget by 12 and 19 above the same period of last year. And non-vascular interventional radiology procedures were above budget by 21 and 32 above the July of 2018's volume. So again, cath lab was also busy. Our deliveries were for July of 137 were below budget by 1, almost budget, but they were 5 above July of 2018. Looking at non-ER outpatient trend, our non-emergency outpatient visits of 8,096 were above budget by 808, or 11.1%. These visits were above July of 2018 by 872, or 12.1%. Our lab visits were above budget by 10%. Our X-ray visits were above budget by 11%. Our cardiac rehab visits were above budget by 19.4%. Our short stay visits were above budget by 44.6%, and our infusion visits were above budget by 27.4%. Emergency room visits of 4,448 were above budget by 19, and above the same period last year by 390 visits, which is 9.6%. Our productivity indicators, our productive FTEs were above budget by 100.3 at 8.1%, at 1,337.7. As you can see, we had an increase in productive FTEs given our volume. Our non-productive FTEs were below budget by 26.2, which is 11.2%, at 207.5. Our total FTEs of 1,545.2 were above budget by 74.1, but our productive FTEs adjusted occupied bed of 5.21 were below the budget of 5.64, given our volume. That really, you can see it in that number. And then total FTEs per adjusted occupied bed of 6.01 were below the budget of 6.7, or 10.3%. So it was a very busy month for us. Additional operational statistics: Washington Outpatient Surgery Center had 486 cases in July. This was 4 below the budget of 490, but 7 above the July 2018 volume. Our clinic visits of 3,304 were below budget by 52, 1.5% for the month of July, but 42, or 1.3% above the July 2018 volume. We had seen an increase in Washington urgent care visits by 47. Our Nakamura clinic was down by 32. A Warm Springs clinic was down by 18, but Ohlone clinic was up by 31. Looking at our payer mix, the preliminary payer mix information for the month of July, government-sponsored patient revenue made up 72.5% of total gross revenue, which is above the budget of 71.9%, but below last year's percentage of 73.5%. Our HMO revenue was 2.8% of gross revenue, which is higher than the budget of 2.6% and higher than last year's percentage of 2.6%. PPO revenue was 22.9% of gross revenue, which is below the budget of 23%, a little bit below by 23%, the budget of 23.1%, but higher than last year's percentage of 22.4%. Private pay revenue was 1.8% of gross revenue, which is below the budget of 2.4%, but higher than last year's percentage of 1.5%. So you probably saw some of that shift from private pay up into Medi-Cal. In terms of our key financial statistics, days cash on hand for July ended at 155 days. It's down 9 days from last year, from last month. Some contributing factors: this was a 3 payroll month for us, and also we did a year-to-date pension and OPEB funding, which is equated to 14 million or 12 days. Also, our days of gross revenue and accounts receivable were 55. And we had, there were $728,970 in charity care applications pending or approved in July. And lastly, our summary of homeless patient activity. There were 187 homeless patient encounters in July of 2019. Our estimated incremental cost of Senate Bill 1152 for the month of July is $73,000 approximately. Estimated total unreimbursed cost of homeless care for the month of July is $601,000. We're going to now show up since starting with July, so that's the total unreimbursed cost for the beginning of this year. So those are the statistics for July.
Thank you. truly was a busy month.
It was a very busy month, and
Yeah.
staff were working hard. Everybody really was pitching in and helped in a number of ways.
July's supposed to be vacation month.
I know I know it was one of the busiest Julys I think we've had in quite some time.
Interesting. Okay, we're down to our action items. We've taken care of action item A. We're down to action item B. We'll have that presented by Director Yee.
Mr. President, in accordance with district law, policies, and procedures, I move that the Board of Directors authorize the Chief Executive Officer to proceed with the necessary contracts to complete the 5 West improvements for an amount not to exceed $250,000.
Second.
I have a motion and a second. Kimberly, would you like to expound on that just a little bit?
Yes, I think we've talked about in the past that we're looking at doing some upgrades to some of the patient floors in our main tower. And as part of this renovation, we're converting our rooms on the 5th floor from semi-private to private rooms. And we're also upgrading the finishes. So we're looking at improving the flooring and the painting, removing of all flooring in patient care rooms in the hallways and replacing it with a vinyl wood finish similar to our 2nd floor of the main hospital and also throughout the Morris Hyman Critical Care Pavilion. So we're looking forward to opening it as private rooms.
Great. Dee, I think we're ready for...
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye.
Director Yee.
Aye.
Director Epen.
That motion passes. That'll be nice to see that happen.
Mm-hmm.
Very
Exactly.
well. Thank you. We're now at a point where we need to adjourn to a closed session. We appreciate everyone's attendance tonight, and we'll be adjourned now to a closed session. We'll now re-adjourn to an open session and announce that there was no reportable action taken in the closed session. There being no further action this evening, this meeting is adjourned.